Go ahead, Linda.
Linda, you may need to unmute yourself. There you go.
Here I am. So I have not had any financial relationships with manufacturers of any commercial products, and the views presented here do not necessarily represent the opinions of the AAP. Next. We're going to provide an overview of coding for children with medical complexity during COVID, the public health emergency, and then also talk about some common coding scenarios related to providing telemedicine and telehealth services for children with medical complexity. Next. So we talk about the difference between the two. The terms are frequently used interchangeably. But for a purist point of view, and for coding wonk like me, we usually are pretty pure. So a telemedicine is actually the synchronous audio and visual telecommunication system used to report a service. Before COVID, there's quite a few codes that are allowed to be reported that way. CMS has one list, and the AMA's CPT manual has another. That's Appendix P. And I've put a link there for, you can compare the two lists and see how they're currently different now that COVID's underway. There are a few codes that CMS has added temporarily, and then there's codes that the AMA is thinking of adding permanently. So telehealth is the broader term. So telemedicine is just one type of telehealth. Telehealth are things like, we've had codes like this all along, telephone care codes, or what we call the e-visit codes, the online digital E&M. Those are telehealth, and they do not require the synchronous audio plus visual. So that's the difference between the two, but unfortunately, you will find that most payers, including CMS, use them interchangeably. So that can be a little confusing. Next. So during COVID-19, there's been things that have been happening, mostly through CMS's rule. CMS, as you know, is the overarching government agency over Medicare and Medicaid, but their policy decisions are only unilaterally applied to Medicare on a national level. Medicaid agencies can then determine what portions of Medicare policy they want to adopt. Same with private payers. So they've been expanded pretty significantly by CMS during COVID, and that includes, things like CMS used to not recognize telephone care. You used to not be able to bill that as a Medicare provider, and now you can during COVID. It's not really known how long these expansions will last. CMS did just extend it a little bit longer now, but it's kind of like kicking the can down the road. So what we're trying to do is advocate for a lot of these good changes to be permanent, such as recognition of telephone care codes. So again, it does vary by payer, so practices need to check with their state Medicaid to see what portions of Medicare they're following. Next. So again, I talked about telehealth codes. So there's basically physician telephone codes, and then ones for non-physicians. And then the same thing for online E&M visits, what we call e-visits, which is basically connecting with your patient through the patient portal. So these are great codes. In fact, the Academy championed the online digital E&M visits. So we were the creator of those codes along with some other of our counterparts. They're pretty valuable codes. Next. So I know this is an important thing. So basically, when you're doing telemedicine, and again, I'm talking about the real-time synchronous audio and visual, there is no difference between a telemedicine visit where time is concerned and when an in-person office visit. So the documentations are exactly the same. So physician must meet the requirements of a given code level, history, exam, medical decision-making, or you can code based on time, meaning 50%, greater than 50% of the time is documented as counseling or coordination of care. So looking ahead, again, I mentioned CMS in its rule made some flexibilities and expansions. And one of the things coming down the road is that there's going to be a significant change in the office visit codes for 2021. The codes themselves are going to change in terms of the time increments. The values are all going to go up. But one of the things that's also happening is that there's a documentation reduction of the burden of the documentation, where what's going to happen is physicians can pick time or medical decision making in selecting a code. You can use either or. You won't have to worry about history or exam. And time will be total time. So let's say you spend an hour reviewing a chart before a patient comes in to see you. That will still be included as the time for that visit. So it's very hopeful that CMS is at least adopting a portion of what it's planning to adopt in full in 2021 for the office visits. Next. There are also some telemedicine modifiers. There's the catastrophe, disaster-related one, and that's really a Medicare payment modifier. And then there's modifiers to indicate that a service is done via telemedicine. 95 is the modifier that CPT uses, and GT is the one that CMS uses. Most payers we find are using the 95. And again, that aligns with those codes in your CPT manual in Appendix P, as in Paul, as I mentioned. So if you go in your CPT manual, you'll see those codes. Next. I'll just touch on this quickly. So preventive medicine codes, they normally were never included in telemedicine pre-COVID. But seeing what happened with our patients not able to come in, get vaccines, the Academy developed a model that we shared with payers and encouraged them to adopt it, where they would be able to provide at least a portion of the preventive medicine service via telemedicine. Obviously, other things, hands-on things, could not be completed. They would get paid in full for that preventive medicine service. And then when the patient could come back in to follow up, there'd be a code, a kind of a placeholder code that the physician reports, and not get paid on that because the payment was already included in the initial preventive medicine telemedicine visit. So the two visits together would make one, like a full preventive medicine service visit. Next. So beyond the pandemic, we are encouraging, when we comment in rules to CMS, we encourage them to adopt policies long-term that enhance payment for virtual services. And so in October 2020, coming up, the CPT editorial panel is going to consider additions to that Appendix P to add codes that have already been permanently added to the CMS telehealth list. So there'll be greater alignment between the two. And then looking down the road in 2021, the panel is also going to look at other additions that other payers other than Medicare may want to add to Appendix P. And again, Appendix P is the indicator of what codes can be appropriately reported via telemedicine. And I've put the link there, and that gives you a good, you can bookmark that link because it compares CPT telemedicine codes versus CMS telemedicine codes. So you can see that there's a little bit of work to get them aligned. And we're going to continue to advocate for maintaining the code payments that have been happening during the pandemic. Next. Okay, so we got some really great questions. So we thought it might be a good place to start is to answer some of these good questions that we actually see on we have a coding hotline. So we see a lot of these questions on there. So the first one is, for telemedicine visits, which include audio plus visual, we can report to office visit code based on level of history, physical exam, medical decision making. If I perform a detailed history with moderately complex assessment plan, would this qualify for a 99214, even if the physical exam was brief, problem focused? And the answer is yes, because like I mentioned earlier, the documentation requirements for a telemedicine visit are exactly the same for an in-person visit. There is no difference. Again, because we're not really differentiating between in-person versus out-of-person. They're both, quote, face-to-face. If we're using the audio plus visual platform. Next. Can I report an audio only visit based on the history and MDM using office visit codes? So for non-Medicare payers, some of their, as I mentioned, Medicare made a rule where now if you did that audio visit and you're a Medicare provider, Medicare would make you report a telephone code 99441 through 3. However, when you get paid, when the claim's adjudicated through Medicare, you would get paid as if you had an office visit via telemedicine. So that's how CMS is handling it for Medicare. It's a little bit, not as clear with non-Medicare. So if they are following that, they would do the same thing. But most non-Medicare payers are instead allowing such audio-only visits to actually be reported as office visits, even though it's not the pure definition of telemedicine, synchronous audio plus visual. And I'll have a question later on about attempted and failed audio plus visual. Next. This question is about when the times start and when they end. In an in-person encounter, billing by time requires more than 50% of the counseling with the patient. It must be documented. Is this the same for telemedicine? And yes, again, documentations for the service reported are the same as they're for in-person visit. So again, you will have to meet the same requirements of a code level. So if you keep drilling that, just remember that they're the same. Next. So when do you start the clock and when you stop the clock? Would you do it when the clinical staff starts? When do you stop it when they contact the patient? Can you count the time in between? So does it depend on the payer, or is it an accepted standard? So the time of any E&M office visit service is the physician time and not the clinical staff time. When you get paid for an office visit, that clinical staff time is built into the practice expense that you get. But the time related to the time with the patient is physician time. So again, as I mentioned, there is a little leeway here because CMS is pre-introducing portions of the flexibility of the reduction of documentation burden for 2021 with the office visits. So what that means is payers that are following that, they will allow you to count all the physician time toward that office visit, even time spent reviewing records before the encounter. So again, for telemedicine, i.e. the same thing as an in-person, office visit level will be able to be picked based on time, meaning all time, and it's defined as all the time providing individuals associated with the E&M on the day of the encounter. So it's not even, you don't have to just be eyeball to eyeball, even over a video, or it can be based on the medical decision making. So CMS has also removed the requirements regarding the documentation of history or physical exam. So, the Academy would always advise that you still document that, but payers would not be using that necessarily to support a level of care. Next. Oh, this is the one I mentioned before. So if you start an audio plus video and the video goes out and you end up just having a phone call. So if you complete most of the visit, how can you bill? Can you bill for audio plus visual? How much needs to be visual? So we look at this, this is of course a gray area, but we feel a good recommendation is that if the service was attempted in good faith and you document it as such, document that the initial connection was established in video before you lost it, it's still appropriate to report the office visit code as if it was a full audio plus visual. We just feel like there's so many glitches now with everyone using the internet, so there's probably going to be a lot more outages, and also there's a HIPAA expansion as part of CMS's rule where you can use things such as FaceTime and Skype, and you won't have to worry about HIPAA violations. So again, we know technology can fail us. So next, please. What are the rules regarding location of a patient? And this is a great question from a coding perspective, but you also have to look at what your medical malpractice says. So that is not mentioned in here, but that's something that I wanted to mention. So I'm going to answer from a coding perspective. And there's a great website that I've put up there. It goes state by state for states that are waiving the in-state licensure requirements during COVID. and most of them are pretty flexible. But the one thing you may want to do is check with their medical malpractice insurer, just to dot all your I's and cross all your T's to make sure that that portion of it is not in violation of your policy. Next. Okay, this is about a facility fee for telehealth transmission, and there's been also greater flexibility on this with CMS. So we support the payment of a transmission facility fee to help compensate for all the extra, practice expense that practices have. So we found that our Department of Federal Affairs and State Government Affairs, about 32 states will reimburse some kind of transmission fee, facility fee, or both. And we have a few examples in here, such as Wisconsin, what they've done. They've Medicaid allowance for payment for all originating sites. And then in Massachusetts, there's guidance for additional information on the provision of healthcare services, such as allowing a distant site to prevail a facility fee in certain instances. So there's been some flexibilities on this under COVID. Next. Can both a pediatric and adult provider bill for a joint telemedicine visit transmission? And yes, this is a CPT tenet that if two physicians are of different specialties, and even more so if they're different tax IDs, if they present two discrete E&M services to a single payer for the same date of service on the same patient and documented as such, there's edits on codes are not across physicians. So if you've ever heard of NCCI edits or McKesson claim check edits, those are all within one physician and what he or she can bill for a single patient in a single encounter. Edits don't go across physicians. And just looking ahead, we are working with our specialty sections to develop a model to help promote joint telehealth visits by providers for a series such as like transition of care or care coordination, because we know that's going to be happening more with the pandemic. Next. Will there be a limit on the number of visits that a patient may have under telemedicine or telehealth? So any limits are based on the coverage policy that a payer has for in-person visits. And having more than one provider on a phone call, most payers follow what they call their consultation policies, like if they would pay for a subspecialist to talk to a primary care physician and vice versa. So really it just aligns with what the current payer policy is for in-person visits. Next. Oh, this is a great question because this is still kind of under consideration. If telemedicine appointments are scheduled outside of posted office hours, can you bill those after hours codes? And I've listed them there, the 99050, 99051. These are the back of your CPT book. They do not have RVUs assigned by Medicare, but many payers do pay for them because they find that it prevents, trips to the emergency department or trips to urgent care, and actually pays for themselves. But it's not specifically been addressed in CPT. And at the AAP, we tend to be, if we're interpreting a gray area, we tend to take a conservative bent because we always want to keep our members safe from any type of, claims or fraud and abuse allegations. So we look at the actual code description, and it does say in the office. And so, but we right now feel like with the way the pandemic is, in the office has opened up to parking lots and tents in parking lots. So we feel it wouldn't be entirely inappropriate to use those codes, but again, unfortunately, it comes down to the adage, check with your payer. But they're interesting codes to think about, even in the context of telemedicine. Next. These are some resources we have. The second one is what we call the coding during the COVID pandemic. We call that our living COVID coding document. It really, we update it really frequently, and it's got Medicare information, ICD information, CPT information. We talk about that preventive medicine advocacy that I mentioned during the first part of my talk. And we also have a real good, robust list of frequently asked questions. And then there's some other really good resources on there too.